The next presentation is primary posterior tracheopexy at the time of esophageal atresia repair significantly reduces respiratory morbidity, to be presented by Dr. Samala Mohammed.
Thank you. Esophageal atresia with tracheoesophageal fistula is often associated with tracheomalacia, which increases respiratory morbidity. It's defined as the excessive dynamic collapse of the airway, impairing airflow and mucociliary clearance. There is a general misperception that infants may outgrow tracheomalacia, and while this may be possible for some, we lack the ability to predict who will and who won't, and the burden on the child while waiting it out can be significant. Some with severe symptoms, such as blue spells or failure to extubate or wean respiratory support, are considered for a tracheostomy, while others endure various respiratory symptoms over time. The objective of this study was to investigate the impact of incorporating posterior tracheopexy at the time of initial newborn EATF repair on respiratory and perioperative outcomes, particularly within the first year of life. This was a retrospective study across 2 institutions to include all consecutive newborns with gross type C or D EATF over a 5-year study period. Neonates had either undergone posterior tracheopexy at the time of initial EA repair, the EA plus PT group, or not, the EA group. Our main outcome of interest pertained to respiratory morbidity. We also looked at postoperative complications and nutritional status. A total of 63 newborns were included, of which 21 underwent posterior tracheopexy up front at the first operation, whereas 42 did not. Babies in the tracheopexy group had a slightly greater birth weight and were more likely to have had moderate to severe tracheomalacia identified on initial bronchoscopy. Operative times were similar between the 2 groups. Most babies had an open approach, and babies in the tracheopexy group were more likely to have been operated on by a surgeon with subspecialized thoracic practice. There were no major differences in terms of respiratory outcomes on the index hospitalization or ICU length of stay, but babies who did not get a tracheopexy up front had a significantly longer total length of hospital stay. There were no differences in relevant postoperative outcomes, esophageal leak, chyle leak, vocal cord injury, etc. And within the first year of life, infants who did get the tracheopexy, were significantly less likely to have respiratory infections requiring hospitalization. They were also less likely to have blue spells. In fact, no infant in the tracheopexy group had a blue spell or a respiratory infection requiring hospitalization within the first year of life. From a nutritional standpoint, the median Z-score in the tracheopexy group was 0.24 compared to -1 in the non-tracheopexy group. And overall, of the 42 infants who did not get a tracheopexy up front, 10 lingered with severe symptoms warranting a delayed tracheopexy within the first year of life, whereas no infant in the EA plus PT group needed additional airway surgery. Others have reported on ALTs or blue spells in the EATF population with rates around 22 to 27%. Our rate was 19%. Regardless, non-tracheopexy management approaches have demonstrated a risk of ALT recurrence. Notably, no infant in our study who had a tracheopexy for blue spells or ALTs, a delayed tracheopexy for that reason, had a recurrent event. Others have also reported on posterior tracheopexy in neonates using the minimally invasive strategy with encouraging results. Strengths of our study include its large size, its comprehensive assessment, its sustained long-term follow-up. Limitations we acknowledge: retrospective and non-randomized study design. We acknowledge selection bias, as neonates were essentially chosen for tracheopexy by surgeon preference for bronchoscopy findings, and the fact that all tracheopexies were performed by surgeons subspecialized in thoracic surgery raises the issue of generalizability. The 24% of delayed tracheopexy rate you may consider to be high, and in fact, one limitation may be that our threshold to operate on tracheomalacia may be lower than others. Nonetheless, we demonstrate that posterior tracheopexy, when performed by surgeons experienced with the procedure, can be performed safely in the neonatal period at the time of initial EATF repair. It's associated with significantly reduced respiratory morbidity, less hospitalizations, no blue spells, and it significantly improved nutritional outcomes. Among patients who didn't get a posterior tracheopexy, 25% developed symptoms that warranted delayed tracheopexy within the first year of life. We thus recommend that posterior tracheopexy under bronchoscopic guidance be considered at the time of initial EATF repair at surgeons with experience in surgical management of tracheomalacia in order to continue to improve morbidity in this population. We caution against widespread implementation as the technical execution and potential risks of the procedure need to be balanced against the perceived and demonstrated benefits. Truly implementing this broadly requires further thought and investigation. Thank you.
This paper is open for discussion.
Romeo Ignacio, San Diego. Nicely presented and congratulations on your work. I know it was the surgeon's preference to do the posterior tracheopexy, but can you give us a little bit more detail? What was their indications, especially on bronchoscopy findings? And number two, I'm trying to get from your work, who actually needs the posterior tracheopexy? Again, great work.
Yeah, the first question, it could very well be that the surgeons who were doing the bronchoscopy, if they were subspecialized surgeons, they were more likely to identify or diagnose the malacia, and therefore the discrepancy up front with the bronchoscopy findings. With respect to who needs it, I think we would argue that you should view this as more than just an esophageal anastomosis that needs to be achieved, and recognize that there is significant respiratory morbidity, and therefore all babies, unless you meet contraindication criteria, of which there are some, should be considered for the tracheopexy up front.
Just a quick question. Congratulations on a great application of a technique that many of us used for vascular rings because it's easy to accomplish at the same time, but now your universal application is very interesting. But you mentioned that the diagnosis of tracheomalacia was important, and when you endoscope these babies, all of them have some pretty severe malacic findings. How are you defining tracheomalacia for those centers that eventually may want to apply this and be able to understand which babies this is going to affect the most? Thank you.
Our diagnostic classification for tracheomalacia has been published, but essentially we're looking at various things: the cartilage shape, the percent of intrusion of the posterior membrane on a good, thorough, three-phase dynamic bronchoscopy.
Hi, Samir Gadapali, Ann Arbor. I was wondering, how many of these patients were done laparoscopically, and does that impact your ability to see malacia and plan out where you would do your tracheopexy? Thanks.
Yeah, I think 14 or 15 total cases in the 63 were MIS, but when we looked at is there more blue spells or the incidence of blue spells, MIS versus open, in fact, the percentage was similar. Of the 8 babies who had ALTs within the first year of life, 2 of them had happened to have had the MIS approach up front, and the remaining 6 had had the open, and ultimately the percentages were the same.
That's a lovely talk. Brian Gilchrist from Brooklyn, New York. But I have 2 questions for you. I do 4 or 5 of these a year, even when I was across the street from you guys. And I've never done a Pexy. I do 4 or 5 every year in Brooklyn. My question to you is, aren't we the subspecialist surgeons that you keep alluding to?
Yeah, I think it's hard to actually implement this in real practice for everybody with their next newborn type C. And in fact, even for us, it's not like we started doing this in neonates. We didn't. There's a long history of tracheopexy in the secondary setting for kids who have had an EA repair in the past, from where we first began doing these procedures and perfecting our technique, and only then have translated it into the neonate. So yes, it is, realistically, I think it is going to be a challenge how to truly reap the benefits of incorporating this and how to technically accomplish it.
Thank you very much.